That was an interesting presentation. Is there any kind of a lucky coupon or something for the men, Ben? For the participants? No? Special offers? I'll stop here and then I'll run fast. Okay. Mercedes-Benz is being promoted here. No, seriously, why? You know, there is an evolution of dentistry wherein root canal treatments were the niche. Okay? Then came the different kind of prosthetic options, the crown and bridge work. Now the niche market is dental implants and aligners. Aligners Tootsie has taken over. Okay? They are delivering it at home. Implants, they can't do that. And you know, a dentist, he can afford this Mercedes-Benz with this implant treatment. Not one, many. Okay? Now your affordability as a dentist has reached to a higher level. That's why people are coming and promoting here. Let's get back to business. Okay, I'm fond of showing my home. This is my first case of, today I'm talking guided implant placements. Okay, this also I want. This was a 28-year-old person with an kind of an aggressive periodontitis. He came with the problem that very shortly he's going to get married and he wants the teeth. Okay? So when we took the necessary investigations, it was not at all possible for us to do it on a conventional way of, you know, placing the bridge and all that. He had to go in for a full mouth implant rehabilitation. Now, treating a patient with aggressive periodontitis. Now, one of the most neglected things in implantology is the pre-existing periodontal condition. When the patient has lost the tooth because of periodontitis, you think it will not affect the implants. It will definitely affect the implants. So, always treat the periodontitis, then you place the implants. You can charge them for that, no? Extra money you will get. Okay? Now, the whole concept of this is you reduce the microbial load in the mouth so that the implant gets more lifespan. So, when you're treating an aggressive periodontitis, there is a big load of microbial deficiency or the big load of microbes which have destroyed the natural mechanism in the mouth. So, to treat that, it requires a special attention where you extract all the teeth, put them on a course of low dose antibiotic therapy, okay? Take a salivary count of the microorganisms before and after the treatment and then go in for a full mouth rehab. This is the protocol that you need to follow. So, this patient, we gave him the full mouth rehabilitation. On the one side, we did the sinus elevation. On the other side, we had planned it and we thought we'll put a few more implants on the other side. But once this was restored, he was very happy and he got married. You don't know what happens after marriage. Okay? So, the same thing happened to him also. He didn't come back. How many of you are good with your mobile phones? Raise your hand. I know it's 4:30. They are serving all that, you know, and I'm just looking at you guys and standing and talking to you. Come on, how many of you are good with your mobile phones, smartphones? If you're good, the Mercedes-Benz will be there at your doorstep in the next 2 to 3 years. Okay, why I'm telling this? Everything is going digital. Everything is going digital now. If you're not good with your phones, you will be bad with your laptops, you will be bad with the digital process of the implant planning. You will not understand the head and tail of it, and a company person will come and dominate. Okay? So if you are a gadget freak, you're going to be one of the leading dental practitioners in the next 5 years. Okay. That was just to wake you up, okay? Now, there is an evolution of dentistry. Now, the digital is overtaking everything. Now, what we see actually in the patient's mouth of all the plethora of problems is just the tip of the iceberg, what we see like a crown. The whole thing is embedded inside, okay? And until the patient comes with some issue, some problem, you will not exactly realize what is going on underneath. So before anticipating what is going on underneath, you make sure that nothing happens underneath. Okay? So I myself title my presentation as this. Okay? I know the slang of it. Okay? Any other slangs that you can imagine? This shows that you guys are very poor with your smartphones. Okay, so this is, wow, that's fabulous. Isn't it? What were you guys thinking? The coffee and the tea is working too much. I know. And the banquet is lined up next. Morning also I told everything, whether it is digital, conventional, stick on to the biologic basic. The moment you move out of it, your treatment is going for a toss. Okay? Now, whenever you opt for implants, always check what they're offering for. Check the track records, surfaces. Now, most of the implant companies have a very good surface. Osseointegration is not at all an issue with many of the implants. But still, if there is a failure, then that means there is something wrong in the surface as well as the way you start working on the patient. There are a lot of minor things which get to the success platform or the success of the implant. Now, most of the implant designs, it's all endosseous, so it is quite tapered, and every surface is different. As you go from the top to the bottom, it is more flat, the pitch of the screw. As you go to the bottom, it's more pointed. That means it cuts at the bottom and it fits at the top. Okay? And when I'm talking about the DO implant systems, they have a unique feature of, I like this one, the platform switching. The platform switching is a concept wherein the abutment when you place, it gives a very nice area for the soft tissue to form. Morning I was telling, you should always maintain that soft tissue, the epithelial cuff. The platform switching, it was an accidental finding. In one of the Japanese studies, the dentist was using the implant. Earlier it was the implant dimension, same was the abutment dimension. So the company people didn't give him the same dimension of abutments, they gave him a smaller one. He used the smaller one, and on a long run he noticed that there is a very good soft tissue coverage and less bone loss when you are using a smaller size abutment for the implant. So there evolved the concept of platform switching, and that is been incorporated in these implant systems. The other most important thing or other fancy thing, good thing about this is the double contact. Now, once you place the abutment, it contacts at 2 points, A and this. Now, what happens when there is a contact at 2 points, there is less of movement. That is, there is more stability. The most common problem once you start practicing implantology is the patient keeps coming to you with the crown mobile. Means the screw is loosened. That is a junction where the crown meets the implant. Okay, all the forces which are laid on it, luckily, will not get transferred onto the implant. It is the screw which takes up all the load and it moves. So in one way, it is good, like all the micro movements is taken up by the crown and there is screw loosening, and once you tighten the screw, it's going to be fine. But just tightening the screw will not solve the issue. If at all there is an occlusal change or occlusal correction, you got to correct it. When you are repeatedly changing or tightening the screw, make it a point that in one of the recall visits, in once in 2 or 3 years, please change the screw. Otherwise, every time you tighten it, the screw becomes flat. Next time you put the X, it will be just dangling over there. That's a very crazy situation wherein you have to cut out this, that, and all. Finally, it's a big mess. Okay, so this is a clinical tip where you call the patient. The patient has to come for a recall checkup once in a year, whether he has a problem or he doesn't have a problem. So every 2 or 3 years, depending upon the occlusal load, you change the inner screw. That gives more life to the implants. The lower aspect of the implant is concerned with osseointegration. If you have bone, bone has 2 parts. One is the metabolic bone and the functional bone. If you imagine this as the bone or the cortical plate, surrounding it is the functional part, where it takes up a lot of load. The inner trabecular area is the metabolic part. Now your implant is more in the metabolic part, which is full of vasculature. Now, your surface of the implants should be rough enough to activate or to allow the osteoblast to come and attach to it. You know how they have designed the implant surfaces? The osteoclast has a zigzag movement and it leaves a pattern. Osteoblast will identify only that pattern. If that pattern is not there, the osteoblast will not come and get attached. So most of the implant companies in their R&D, they replicate the osteoclastic pattern. Okay? Now, in this system of implants, lower part of the implant has a macro surface which replicates the osteoclastic action to facilitate osseointegration. All right? The top portion, it has to get merged with the cortical plate, then the trabecular area. So the micro surface allows that. Now you imagine cortical plate is thin and it is less vasculature. So the microorganisms, if at all, if it is there, then it will have a very easy way to breach the cortical plate than the trabecular area. So you have a micro surface and a macro surface. There is always a kind of an upgradation in your career. Okay? Every now and then, you should attend the conference. Once in 2 years, you should attend the basic of implantology, hands-on. Okay? It's something like you watched movie for 10 times. On the 10th time, you'll see that you have missed out that scene earlier. Okay? Even now, after 15 plus years of my experience, I still attend the basic implant course once in 2 years. Okay. Now, this is upgradation. You need to be a literate in dentistry. A person is an illiterate who doesn't upgrade himself. Now, the present upgradation is going digital. Now, what are the advantages? Um, it is something like how you are using an old analog phone to the smartphone. Isn't this better, the smartphone? The same way. Okay? It reduces. The only drawback what I found when I was learning digital is the learning curve for you, which you will pick it up very fast. Even if you have placed 10 conventional implants, the digital part you will pick up like anything. The other drawback what I found is to communicate with the company and the lab for the kind of exact replica of what treatment you desire. Okay? Now, these are the only two drawbacks. Otherwise, I found it very amusing, especially when it comes to the time factor. It reduces the time factor of the treatment by several weeks. And it is a very good option when you have to go in for a immediate provisionalization. I'll show you a few cases where you have done that immediate provisionalization, and it's come out really good. Patient is very happy. Nowadays, the concept of place the implant and load, the immediate loading is on the move. If you are not with it, yes, the scientifically you have to consider all the facts to load the to give an immediate loading. This might be some of the questions what you have if you are a beginner. Yes, you can have a immediate jump into the digital dentistry, but what I personally feel is you should at least have a few cases of conventional where at least you know the tactile sense of working on the thickness of the tissues, the tactile sense of drilling into a hard bone, a soft bone. So once you are aware of it, sometimes with the digital what I felt is the tactile sense is a little reduced. Until you are really experienced, you can actually make out what's happening. Otherwise, for a newbie, it becomes a very tough task. With the digital, yes, you can do some precise treatment planning. This was a case which I'll discuss later, where the patient didn't have bone on either side, and it was supposed to go for an immediate loading. We had to engage the crest in the sinus. That was the only bony wall which was left out, and that we could do it precisely with the digital planning. Now this it's very hard for you to depict on the conventional level. The basic workflow or the learning curve starts from, if a patient comes to you, how do you plan? First you get the digital scanning, all right? Then you send the CBCT DICOM files. They will merge the digital scanning and the DICOM files, and then they will send you the surgical stent. Now with the surgical stent, once you place the implants, now when the planning is happening, they'll prepare the surgical stent, they'll prepare the provisional abutments or the customized abutments and the temporary crowns. The concept of customized abutments is you get a nice gingival contour. Now with the regular abutments, you will have one flat, round kind of a finish line. But in a customized abutment, you get that finish line exactly matching your soft tissue pattern. If you remember the soft tissue pattern, incidentally, you have the papilla at a higher level, buccally and lingually, it is at a lower level. Your customized abutments, you will get it exactly that way in that particular teeth, how it is. So this is the workflow. Okay, I have a small video as to how this workflow, this will be helpful for the people who are getting into the hands-on following this. So basically you start with the scanning. The CBCT data and the scanning will be merged. The CBCT file will be sent as a DICOM file to the lab. So once these two are merged, the data will be analyzed. Now here, I found it so interesting. They follow first the smile designing concept. Secondly, they follow the occlusal pattern, where exactly the load has to be put on the temporary processes. Everything is planned, and then last they will build up the surgical stent and they will plan the implant. So it is again a prosthetically driven treatment planning, which is the ideal way of how you are supposed to treat implants. That's the CD model and the guide printed. And the temporaries what we get has a nice gingival finish also. It almost looks like your permanent restorations. Most of the patients are very happy with the temporary itself. The learning curve has a kind of a typical protocol as to how you have to go about with the drilling. All that will come like a map for you. You have to just follow that. How many of you have started with the digital or the guided surgical approaches? You can keep the cup for a while and then lift your hands up. Okay, very few. All right. So that was the basic workflow. In the first thing, what we have to discuss in the digital concepts is the surgical stent. Okay, there are different generations of surgical stents. Here, what we follow is a kind of a surgical stent which is prepared with the CD, the CBCT, the oral scan, and a 3D guide stent. This is the 5th generation of the surgical stents if you are putting up into the academic level. And this is the present highest form of the surgical stents what you can get for. There is a big way of doing it on the at the lab level, but what you get is really amazing. Now, when we compare to the other generation of surgical stents, the present or the 5th generation of surgical stents what is being provided by DO, it has a very, very, very less area of gap between the stent and the tooth. This makes the error as minimum as possible. If there is a big gap, then you will actually not enter exactly where it is. Your drill will be dangling here and there and you will not hit the right spot. Now that can be avoided with the 5th generation of the stents, and the kind of deviation is very less, and it's, it's less than a degree. That is 0.26 degrees. That is very, very negligible. Your surgical stent also comes with a flattened tooth surface. Here, you don't have a bulged tooth surface. You have a flattened area so that if the mouth opening is limited, it is easier for you to insert the instruments. Otherwise, if you keep it at the occlusal level and the patient has a less mouth opening, or if you are working in the last molar area, it is very difficult for you to insert the instruments. This is the basic kind of a drill set what you have to know. People who are very afraid of too much of a bloody field, reflection, incision, this option will be good because we here use a tissue punch. Now a tissue punch just takes the scoop of the tissue. Since it is all digitally planned, you exactly hit the area where the tissue has to be removed and where the implant has to be placed. So you have a tissue punch. Now in some areas where the bone is not flat or slanted, you can't keep a drill and the drill might slip. So for all the cases, they do a little bit of bone flattening, that is again planned in the surgical stent. So you do a bone flattening, then you use the subsequent drills. This is an abutment profile drill, and these are the other drills. I'll talk about it in picture. This is the kit, what you will get in the hands-on today. There are other series of kits. Now, whenever you're planning, this will be the series. Now, this will be the picture of a particular drill or a particular osteotome. You might be confused, it's like, what is this? So many things. Once you understand the concept, okay, here they mention D3, D1, D2. Many a times, the CBCT results, what they predict of the bone density as a D1 or D2 might not be exactly the same. Many a times, the clinicians feel that, okay, they are reported it as a D2, when you are drilling, it's more of a D3. So even when you're drilling, if you feel the change, you can follow the protocol up to the D3. If it is D2, you can extend it up to the last drill. This I told you, the other systems has a very less, and why it is more, because the sequential drilling reduces the amount of heat generated in the drill. So the more sequential drill, the less trauma and the less heat generated. When there is less heat generated, there is less bone necrosis. Now this will be the first drill. Once you place the surgical stent, you use the tissue punch and create a tissue punch like this. You know, no incisions, less bleeding, less injury, and faster way of healing also. Next, you use the blown flattening drill. Now, one of the important changes what you will find in using this system is they run the drill at 100 RPM without irrigation. Okay? Now, you should ask me, just now you told that the heat causes necrosis, right? Now, there is a heat test conducted at the R&D of in Korea, where you dip the drill. Okay, now the contact time is very important. 100 RPM, less than 10 seconds, it's around 39 degrees centigrade is the heat generated around the bone. Okay, now what is the temperature wherein there is necrosis of the bone? It is 47 degrees centigrade. Now 47 degrees centigrade is the point at which the alkaline phosphatase enzyme starts breaking, leading to the catastrophic events of bone necrosis. Okay, now 39 degrees is much away from it, and the catch is 10 seconds. Don't keep drilling it, and you don't need that also. You just do this and take it out, your implant bed is prepared. Once you drill it, in the drill, you'll get all the bone shavings. You can collect that and use it like an autogenous graft. All right? The rest of the things, if you feel there is some more debris, we recommend that you use a copious irrigation after every drill. Okay, you drill for 10 seconds and then irrigate it nicely. Otherwise, what I personally experienced in the older generation of surgical guides, you have a nice snug fit of the guide, but when you're drilling, the saline keeps flowing out. It doesn't go into the osteotome. And that you are running it under 500, 800 speed. Bone necrosis tend to happen. One is the high speed and the contact. Now here both are reduced to 100 RPM for less than 10 seconds. So the heat is also less and there won't be any kind of a bone necrosis. These are all the advantage what I just told you. Now once you flatten the bone, then it is the time for the initial drill. Now this determines a lot. Earlier in the systems, what we used to encounter is, you have a sleeve, on that you have to place a guide like this into the sleeve so that your drill, the initial drill is a 2 mm drill. The C will be a larger drill to accommodate the implant. So to accommodate the 2 mm drill, we have a drill tube. In the older systems, what I have seen is, once you put your initial drill, it used to dangle, it used to shake a lot. Okay? Now, in this system, that has been completely eliminated, wherein the movement of the slot is less than 1 degree. Okay? When I say 1 degree, now if this is the slot and if I keep the drill like this, 1 degree here it will be more. As you go down, it will be much wider. Okay? Anything more than 5 degrees will have a complete distortion in the osteotome. So less than 1 degree is a very, very acceptable and a very neat way of doing the guide. Now this is a kind of a comparison with one of the brands. Every brand has its own updations. These were the older updations, wherein not only this system, the other systems also, there was a glitch. There was a slight glitch in the way they gave the surgical guides. Now this system, they have overcome that with a lot of R&D. Now the less than 1 degree shake. Now this gives a very neat picture of how actually the deviation happens and how less is the deviation in this system. These are some of the unique points which I am highlighting. Okay, there are other lot of features. You can always visit their website or contact and you can get in more information. I am just highlighting on the salient features. This is for the sleeve. Okay, the sleeve and offset. These are the two words. You don't worry about it now. When you're doing the hands-on, you will understand a lot about it. Okay, now you have different types of gingival thickness. I told you in the earlier talk, there is a medium, thin, thick. Now every tube cannot accommodate that. So to accommodate that, the different thickness, they have a different kind of a offset. That is the offset. Okay, so they will explain it in the kit. Now this has been evolved with lot of different simulations, the finite element analysis, and working on the models where the exact positioning of the implant just under the crest, either at the crest or subcrestal is what we desire. And this is the kind of offset what I was talking. Bone is flattened. Now you put the guide and place the initial drill with the offset selected. Again, that will happen at 100 RPM at 55 NCM as the torque without irrigation. So once you did the initial drill, then you go to the final drills. Now, if you see, the drills are parallel, isn't it? Now, how is your implant? It is not parallel. It is like on the top portion it is wide and it narrows or the tapers down. To give that shape, we have something called as the profile drills. The profile drills help you give that kind of a shape with a nice primary stability when you are inserting the implants. Otherwise, what happens in most of the systems, most of the drills will be flat or parallel to each other, and you have a kind of tapered implant. So when you're placing it, you might under drill or over drill it. Now you have to keep detorquing and torquing, detorquing and torquing. So that will be avoided with the profile drills. Now most of these cases will go for an immediate loading. So when you're loading it immediately, you have to accommodate the abutment. To accommodate the abutment, you do something called as the abutment profile drill, where you place the drill and the drill slightly widens the superficial osteotomy, so that the abutment can sit in that and you get a nice soft tissue cuff. You have different offsets of implant connectors depending on whether you are taken a 9 mm offset, 10.5 or 12. You select the, you have the different markings on the implant connector. So you have to insert the implant according to that depth. This is the customized abutment what I was telling you. Now this gives a beautiful emergence profile and a beautiful, once you place the crown, the kind of the soft tissue adherence onto the prosthetic part will be amazing. Especially this works out wonderful when you're working on the aesthetic zone. Okay, we'll discuss some of the cases. First, the partial edentulous, patient with a failing bridge. All the planning goes on. When you're planning, when they send you the plan, they will exactly tell you where the implant will be positioned. Okay, if any kind of a bone flattening is needed, any kind of alteration is needed. Okay, there is the now the concept of bicortication that is used in basal implantology, wherein you engage both the cortex to give a very good. Now in the conventional also they are slightly modifying the procedure wherein they are engaging the bicortical plate. One is the sinus floor and the nasal floor. So that cortex you just touch and engage, don't penetrate it. Okay, now this amount of precise drilling and the precise flow of the implant just touching the other cortex to get a bicortication can be done only with the guided planning. Otherwise, it is in the conventional part, it is very, very difficult. I'll show you those things, how we have done the bicortication. Now, once the planning is done, you get the surgical guide with the temporization. Okay. Now, this is what is the kind of bone what I was telling you. Now, this becomes a nice chunk of autogenous bone which you can use it when needed in other areas also. Implants are placed with the customized abutments. A temporary prosthesis is given on the same day. Now all this comes as a package. You have to just place the implants and fix the temporary crowns. This is the immediate OPG and see the well placed implants. And this is the kind of final restoration. Now, this is a very interesting case. The patient is just 45 years, uncontrolled diabetic. The HbA1c level was about 8.5. Now, when you are treating a diabetic, there are a lot of flaws that the patient comes with. You know, it's not about the sugar levels being very good at the time of placement of the implants. The sugar level should be good throughout the healing period and after that also. Okay? And mind you, they don't listen to you. smokers and the sweet people, they don't listen to you at all. Okay? Smokers, they've said, I just quit. Just quit will be as fast as just started. Okay? And diabetics also, they have neglected their health so much, that is why they have become, they are diabetics now. You can't expect that to just change over a time. So, this patient was an added benefit for me. He was a smoker and a diabetic. And he was my close friend. So, that means they won't listen to you at all. Okay, so we planned the implants, we planned 8 implants. Now, we thought first we'll go for all on 6. Then this portion, the bone was not very sufficient. So, I thought we'll place all on 8. 1, 2, 3 and 4. 1, 2, 3 and 4. This is the case where I told you you can place the implant in the crest. Now, this area was very close to the sinus, so we thought of engaging here. Now, here it is D3 bone. Okay, D3 bone, I told you earlier that we have to do a osseo densification. Okay, now here that can be substituted because you are using a very slow speed. 100 RPM, it just turns. Now, the catch of working or the trick of working in a D3 bone is if you are placing a 4.5 millimeter of implant, stop 2 drills before, say about 3.8. The next will be 4 and 4.5. You stop at 3.8 and place an implant, you get beautiful primary stability. Okay? So, here, apart from the planning, whatever they give you, you should also have a little bit of knowledge of manipulating the treatment plan. That comes only with experience. Otherwise, they guide you in a good way where they give the idea as to where you have to stop for a D3 bone. So, the planning was done. This is what we discussed. This is the kind of images what they sent, and in, for example, in 1-1 area, 3.8 into 13 was the length of the implant and about 10.5 as the offset. This is the final placement of the implants, and you can see the customized abutments. Okay? In this area, okay, we did a GBR, means the label plate was very less. So, I placed the implant, did a little augmentation and placed the membrane, and I didn't put the customized abutments, it is submerged. The rest and all is out, only this is submerged inside. Now, on this, the patient didn't opt for a temporization. So, what we did was, after placing the customized abutments, we took a scan of the customized abutments and we sent it to the lab where a PMMA processes. PMMA is a very nice material for temporization. So, we got a PMMA, it gives a finish similar to porcelain and it's very good as a temporary material. It doesn't take up that kind of a load, or it's not hard and it is not heavy, very light. You can just, fix it onto the implants. Now, mind you, this patient is a diabetic smoker. Immediate loading is absolute contraindication. But what made us to load is the kind of torque. Now, when you are placing a full mouth, if you are getting a combined torque of, I'm not getting the figures. Okay, you should get a combined. So, for example, in this you get about 40 NCR. This you get 40. Everything should be more than 40 and it should add up to a particular value. Just find out the value. So, we planned it in such a way, we communicated with the lab in such a way that we predicted the kind of torque and it happened, and we had to temporize this. Now, I will show you these individual implants, how was the planning and how it came out. Okay. Now, this is the planning of 1-1 where they said that there was a tooth, atraumatic extraction, curettage and GBR. Now, here I don't want to extract the tooth. I told you something about socket shielding. Okay, if I remove this tooth, I will lose this bone. Then I have to do a GBR, which might not be very predictable. So I ask the planning person to keep the implant a little onto the palatal side so that I can slit the tooth and make a socket shield. And that is what is exactly evident here. Can you see this? This is the tooth. This is a CBCT which is taken immediately after a month or so. You can see the tooth which is protecting the labial plate. Now, if I had not kept this tooth, I would have lost bone up to here and I would have had to graft it, and I was not in a position to load immediately. Okay, so this is 1-1. Now, 1-3, the planning says that the implant threads are exposed and the GBR is required. Okay, implant threads are exposed on both the sides. Anchorage from the nasal floor. This is the bicortical stabilization of a conventional implant, where you hit the cortical plate here and just grip it or touch the other cortical plate. See here. Okay, and this is the bone graft what we had done for the GBR, and this is the implant what I told, which is submerged inside. The CBCT finding came that there is a slight penetration into the nasal floor. That is what was exactly been planned. Okay, so this is 1-5, anchorage from the sinus floor. Again, bicortical, and you can see exactly it is just touching, not penetrating the sinus floor. 1-6 area, anchorage from the sinus floor, and here it is. Now, again, this, there was a tooth which suggested atraumatic extraction, curettage, GBR. I asked for a socket shield. And you can see, I know it is more pixelated here, but yes, this is the tooth. Now, see how well these customized abutments are like kind of a grooving there. Now, can't you expect a very good soft tissue alignment on this? You will definitely have a very good soft tissue with this. 2-3, also a socket shield, atraumatic extraction, curettage and GBR. Okay, and this teeth was there, I had to do a socket shield. Now, imagine I extract this teeth, the bone was here. Then GBR till here, wait, you can't load. Instead, even if you have a very thin layer of natural bone, that will sustain, that will be retained if you do a socket shield. Now, for this, we did a socket shield. The tooth is here. Now, there is always a question as to what happens to the tooth. Okay? Now, it might come out over a period of time, or in the previous presentation, I showed a 9 years post CBCT where the tooth is still stuck. Even if it comes out, it will not just prop out like that, it will come out very slowly, like how you orthodontically extrude the tooth. So, when you orthodontically extrude the tooth, what happens? There is bone which is formed as the tooth slides down. So, ultimately, you are in a win-win situation. The patient is also in a win-win situation where this part of the bone is, is regenerated very naturally. 2-5, okay, anchorage from the sinus floor, yes, we have it. 2-6, anchorage from the sinus floor, very close to the sinus floor. Now, in this patient, it was very difficult for us to keep him under the acceptable range of HbA1c. So, what you do is every month you ask them to come report to you with a blood report. Okay? Then I realized also that they can get some fake reports also. Okay? So, what I did was I have an AccuCheck, you come sit here, I will check. So for that, what they do, whenever there is an appointment, 1 week before, they'll fast nicely, they'll go hit the gym, everything. On that day, they will only, you wanted the blood, no, you please take. Yes, it will be normal, but yes, it's a very tricky situation of how we have to deal with the diabetic people. This is a full mouth rehab case with a temporization. I'll run through the pictures. This is the immediate temporization. Now, very nice kind of gingival finish, acceptable for the patient. This was all on 4 case. Okay, customized abutments and immediate temporization. Now here, now to brush just slightly with the sinus, anterior wall of the sinus floor, it's very tricky if you just do it in a very conventional way. So even in the older ways, you have a guide, but not the drilling guide. We had an external guide where you had to fix it, and but this is absolutely more precise. So this is the kind of finish what the patient will get immediately after temporization. You wait. Now this is something called as the progressive loading phenomenon, where you immediately give a temporization, wait for the osseointegration time, wait for about 4 to 6 months, and then go in for a temporary. Now when you're going for a, permanent, when you're going for a permanent, you have to just call up the DO Navi lab. They have all the reports, they have the shade, everything. They will send you the permanents. You have to just take it out and fix the permanents. Okay. Right. Now, there is something called as the twin guide. Twin guide is sometimes when you're holding the surgical guide, it wobbles there. When you're drilling, the whole thing might wobble. You are not exactly sure whether it is fitting into the right position. So to facilitate this, you have some attachment screws, like a tripoding effect, where the surgical stent is placed and the screws are holding on to the bone. Okay? Whereas here there is another concept of twin guides, where they will give you 2 guides. The first guide will be placed on certain teeth. Okay? So you extract the teeth, you place this guide, and you place the implants. Once you place the implants, take out that, extract the remaining teeth, keep the surgical guide, the second surgical guide, and you fix it with implant connectors. Okay? So this patient is, again, I'm seeing a lot of people in the 40s, coming with a lot of, early tooth loss. This patient was a teetotaler. Sometimes it is, bad to be too good also. You should have some bad habits, which will save you. Your defense mechanism somewhere triggered. If you're too good, no, doesn't work out. So he was a teetotaler. He has periodontitis. Okay, so what we did was first clear the perio. Perio doesn't mean that you have to do all the surgeries, open up the flap, no. Depends on what kind of pockets you have. If you have pockets less than 5 millimeters, do a non-surgical. If the pockets are more than 5 millimeters, do a surgical. So for him, we did a non-surgical, that is the LANAP, and this was taken care. Now here, we had to extract all and give him an immediate prosthesis. This is how he came to us. And these, it looks nice, but all these teeth were grade 10 mobile. Okay? All right, so this is what we had planned on all on 6. This was the trickiest one, where there was absolutely no bone. I wanted the implant to be a little more longer, but they couldn't accommodate it. But still, we went ahead with giving a temporization for him. Okay, so here, instead of customized abutments, we use the multi-angle abutments. This is the whole kit what we get. and all these things goes into his mouth. Okay, so before the procedure you show him, देखो ये सब अब we are putting into your mouth. Okay, so these many things. I know it looks a little complex, but once you start working you really enjoy the job. Okay, this is the temporary crown, the twin surgical guides. The best part what I found is this planning is more occlusally driven. One of the most not understood concept in implant dentistry or in general dentistry is occlusion. That is why we still call it as malocclusion. You have a classification of malocclusion. You don't call it as an occlusion, isn't it? Okay, so this is the twin guide I was talking about. The first guide which will engage on the tooth. This is the tooth and you can place 1, 2, 3, 4. In the second guide you place these and you fix it. You fix it onto the implant what you have placed with an implant connector. So the whole of the guide is stable. This is the twin guide concept. The drilling, post drilling, the multi-unit. Wherever we had space and wherever we had extracted the tooth, we use the PRF. This is the autogenous graft, PRF chopped into small pieces, the bioactive ceramics, the PRF, and this is the solution what you get after compressing the PRF. There is a lot of fibronectin, vitronectin in that actually helps in tissue healing. The processes, and it was filled with a lot of composites to fill up this area, and the temporary is ready. And this is the occlusal guide. And this gives a very accurate way, and this actually creates less of stress. You need not bother about which implant is been hit, which implant is not hit. This is all planned and you have to just use the temporary. Okay? Now, this is how once you keep the occlusal plane, now exactly it coincides with the lower. Since you take a digital scan of the bite, it is exactly planned as to which tooth should occlude in which plane with the surgical guide. This case and the previous case, Dr. Arun helped me a lot with this. He is the prosthodontist attached to our DO. This is how we got it finally. Okay. Now individual. Now bone flattening. The bone is flattened. Now you see the slight curvature. We still have that curvature. Okay, little bit of grafting was done. Okay. Atraumatic extraction and GBR didn't require. Little grafting I did here. Anchorage from the nasal floor, slightly hit the nasal floor here. Okay, so this teeth was extracted, that is 2-2, and an implant placed quite good. You see the curvature here and the same curvature. This is 2-3. Okay, atraumatic extraction of this, a little bit of grafting needed. So whatever the autogenous graft comes out with the drill, we can use in this. The same for 2-6. Okay. So from morning you are listening to so much of implants, okay. Let me have a test. Now you spot the implant in this. Which is the implant in this? Chairperson shouldn't answer. He's telling it is 2-2. All for 2-2? Yes? Anything else? Okay, that's it. You won yourself a Mercedes Benz. Okay, and this. Which is an implant in this? This means you are not attentive in the morning. This was the same case what we discussed in the morning. Huh? I know you guys are, really sat throughout. Okay, in this, last, which one? Okay, in this is the other side. Okay. Whatever it is, don't tell it to anyone, okay? In this, it's the same case. Again, you are not attentive. Morning we discussed this case. There is no implants in this. Just because we all know implants, we can't keep putting implants in all the areas. Okay? This is a kind of an aesthetic outcome what you desire, which can be achieved in other ways normally also. Okay? So implant is not always a solution, but it is the best solution. If you don't have any other options, implant is the best option. Conclusion, you draw it because you have been sitting throughout the day. Okay? So yes, I prefer, I had a learning curve. I was very skeptical about going into the digitalization, but I'm very, I feel it is very convenient now. I feel it is, that learning curve is worth that what you want to take. Okay, so there are a lot of advantages and disadvantages what we have gone through. I'll just wrap up my presentation, okay, with a small video. If you're sleepy, get up. This you have to watch. You see this, no? This you can adapt it in your general life also. Okay, so break all the shackles and take that big leap, whether in implant dentistry or in life, to make things easy for you. And now definitely we can always say that, wow, that was fabulous. Okay, thank you. Any questions? No questions? This slide is for me. I showed you so many slides for yourself. One slide I kept it for me. I always keep forgetting to thank people. Okay, so the vote of thanks. Anyway, the last lecture. Thanks a lot, organizing committee, Dr. Binny, you've done a wonderful job. Okay, and audience, first please clap for yourself. You have been here, and I know it is